There's a specific kind of frustration that comes with phantom car noises.
Oh, and this is.
You're driving and you hear this rattle. And it sounds exactly like it's coming from the glove box. So, you empty the glove box.
Still there.
Still there. You check the door panel. You bang on the dashboard. Nothing. Eventually, you take it to the mechanic and he tells you it's a loose bracket on the muffler in the back.
Yeah, that is a surprisingly perfect analogy for the topic we're tackling today.
Right, because we're wired to just implicitly trust our senses. If I hear a noise in the glove box, the problem has to be in the glove box.
Yeah.
And if I feel pain in my arm...
The injury must be in your arm.
Right.
And that instinct, while it's logical, is exactly why so many people spend months, sometimes even years, chasing the wrong thing.
They're fixing the glove box when the muffler is falling off.
Precisely.
So today we are doing a deep dive into a medical mystery that is incredibly common, but surprisingly misunderstood. We're talking about that nagging, vague ache that runs down the side of your arm.
The one that makes you think, I must have slept funny. Or the classic, I've definitely got a pinched nerve in my neck.
It's the standard self-diagnosis journey, isn't it? You start stretching your neck, maybe you buy one of those weird traction pillows from an Instagram ad.
The ones that look like a torture device.
I have absolutely bought one of those. It's in my closet right now, gathering dust.
We all have one. Or you go to the doctor, you get an X-ray or an MRI of your cervical spine, expecting to see this huge disc bulging out. But the scan comes back clean.
Or maybe it shows some minor wear and tear, but nothing that explains the absolute misery you're in. And that's the real frustration point. You're in pain, but the obvious cause isn't there.
And that's where the sources we're covering today come in. We're looking at data from Physio and some recent musculoskeletal research that just completely flips the script.
It turns out that pain running down your arm, it might not be an arm problem at all. And surprisingly, it might not even be a nerve problem.
We are diving into the phenomenon of referred pain, specifically originating from the rotator cuff muscles.
And the mission today is to understand why your brain is essentially, gaslighting you about where you hurt.
Yes, and more importantly, how to fix it. Because if you treat this like a pinched nerve, you are going to be in pain for a very long time.
Okay, let's start with the big reveal then, the aha moment from the reading. I think most people have heard of referred pain in the context of a heart attack, the classic left arm pain.
Right.
But I had no idea the shoulder could play that same trick on a day-to-day basis.
It's actually one of the most common sites for it in the entire body. The research shows that the rotator cuff muscles, specifically the supraspinatus and infraspinatus, are absolute masters of ventriloquism.
Ventriloquism, that's good.
They can be screaming in distress up in the shoulder, but the brain registers the sound as coming from down in the deltoid or the upper arm.
Okay, but why? This is the part I want to unpack first, because biologically, that just seems like a massive design flaw.
It does seem inefficient, doesn't it?
Yeah. Why would the body send a distress signal to the wrong address? It's like sending a fire truck to the wrong house.
Well, it comes down to a concept called convergence projection theory.
Okay, that sounds highly technical. Let's break that down into plain English.
Think of your spinal cord as the main highway for information traveling up to the brain.
Yeah.
You have on-ramps coming from the shoulder, and you have on-ramps coming from the arm.
Okay.
Now, instead of having their own dedicated lanes all the way to the brain, these sensory nerves often merge. They converge onto the same neuron in the spinal cord before the signal goes up.
So the signals all merge into a single lane.
Exactly. It's a traffic jam.
Yeah.
So by the time that impulse actually reaches the brain just sees pain signal X. It knows it came from that general neighborhood, the arm/shoulder sector, but it can't always distinguish if it started at the shoulder on-ramp or the arm on-ramp.
So the brain has to guess.
It makes a probabilistic guess. And here is the kicker. Because the skin on your arm has a higher density of sensory receptors, it's more sensitive. Whoa. The brain often defaults to mapping the pain there.
Oh, wow.
It essentially says, well, the arm is usually the loud one, so it's probably the arm.
That is wild. It's literally a wiring issue where the brain can't identify which car honked, so it blames the
flashy red sports car. The arm. It's a great way to put it.
But the text highlights that this isn't just a simple wiring overlap. There are other mechanisms that make the signal louder over time.
Yes. The term that jumped out at me in the research was central sensitization.
I circled that too. It sounds like something from a sci-fi movie, but in this context, it sounded like the nervous system just learning bad habits.
That is precisely what it is. Imagine a volume knob on your stereo. When you have an acute injury, the body turns the volume up so you notice it and protect it. That's a good response.
Right, survival thing.
But with chronic irritation, like in the rotator cuff, the system gets stuck. It just leaves the volume at 10.
So even a small signal becomes a scream.
Yes. The neurons in the spinal cord actually undergo a chemical change. They become more efficient at transmitting pain. They lower their threshold. So a signal from the shoulder that should be a minor annoyance, a 2 out of 10, triggers a massive response that floods the neighboring pathways.
Which explains why the pain spreads. I was reading about the time factor in the source material, and it was honestly a little scary. It said, longer irritation equals larger pain zone.
It's a sobering finding, but it's crucial for listeners to understand. The research indicates that if you ignore this rotator cuff issue for 6 months, hoping it'll just go away, the area where you feel pain can physically expand.
Because the map in your brain is getting blurry.
Exactly. The sensitization spreads to adjacent neurons. So what started as a pinpoint ache in the shoulder might eventually feel like a dull throb taking over your entire upper arm just because the alarm system is malfunctioning.
That's a huge motivator not to just tough it out. But there was another mechanism mentioned that I think people confuse with knots. The text talks about myofascial trigger points.
Right.
Is this just a fancy word for a muscle knot?
It is, but we need to be specific about what a knot actually is. A trigger point is a hyper-irritable spot in a taut band of muscle. It's a small patch of muscle fibers that have contracted and they refuse to let go.
Stuck in the on position.
Right. And this creates a mini crisis in that specific spot. It restricts blood flow, metabolic waste builds up, the tissue becomes chemically acidic.
Yeah.
This chemical soup irritates the nerve endings.
And that irritation is what gets referred down the arm.
Yes. The source draws a parallel to tension headaches, which I think everyone can relate to. You know how a trigger point in your upper trap near your neck can cause a pounding headache behind your eye?
Oh, absolutely. That's the worst. You rub your neck to fix your eye.
That is the exact same mechanism. The problem is in the trap, the pain is in the eye. With the shoulder, the trigger point is tucked away in the rotator cuff, but the pain pattern is mapped directly to the side of the arm.
Okay, so we have the why. We have the wiring confusion, the central sensitization turning up the volume, and these toxic little trigger points firing off signals. But let's get practical.
Good idea.
I'm imagining a listener right now rubbing their arm thinking, is me? Or do I actually have a pinched nerve? Because pinched nerves are real, and we don't want to ignore those.
They are very real. And treating a shoulder like a neck or a neck like a shoulder is a recipe for failure. So we need to look at the differentiators.
The source broke this down really well. Let's talk about the deep arm ache. How does that feel compared to a nerve issue?
This is the hallmark. If you ask a patient with a pinched nerve, what doctors call cervical radiculopathy, to describe their pain, they often use words like electric, shooting, burning, or zap.
A very sharp, distinct feeling.
Yes, and crucially, that sensation often travels past the elbow, into the hand or fingers.
Right, the numbness in the pinky or the thumb, that's the classic sign.
Exactly. If you have tingling in your fingers or loss of sensation in your hand, looking at the neck is a very safe bet. But referred pain from the rotator cuff is different. It almost always stops.
What stops at the elbow?
Usually, yes. It stays in the deltoid region, that patch of muscle on the side of your upper arm where you get a vaccine. And the quality of the pain is different. It's not a zap. It's described as a heavy, deep, dull ache.
Bone deep. I saw that phrase.
Patients often say that. It feels like it's inside the humerus bone itself.
That matches the phantom car noise idea perfectly. It's this background hum that you can't quite place, but it's just always there. What about triggers? If I move my head and my arm hurts, that's the neck, right?
Generally, yes. If looking up at the ceiling or tilting your ear to your shoulder recreates that zapping sensation, that's a mechanical compression of the nerve in the neck. You're physically pinching the hose. But with the rotator cuff, the trigger is usually load.
Load, as in lifting things.
Using the arm against gravity. The rotator cuff's main job is to stabilize the ball in the socket when you move your arm away from your body. So reaching for a seatbelt, putting a gallon of milk in the fridge, brushing your hair.
The classic ouch moments of daily life.
Right. If you have that deep ache and it gets sharper specifically when you try to lift your arm to shoulder height, that's the painful arc, that points heavily to the shoulder, not the neck.
There was one other symptom that I found really specific and frankly sounds miserable. The night factor.
This is the one that drives patients to the doctor. It's often the breaking point.
Why is it so much worse at night? The text mentioned patients being unable to sleep on the affected side, which makes sense, but also just hurting while lying down in general.
It's a combination of mechanics and chemistry. Mechanically, if you lie on your side, you're compressing those inflamed tissues directly. But even if you don't lie on it, pain perception changes at night.
Because there are no distractions.
That's part of it. The room is quiet, so the noise of the pain seems louder. But also, inflammatory fluids can pool when you're static. If a patient tells me, I have a deep ache in my arm, I can't lift a gallon of milk without wincing, and it wakes me up at 3 a.m. every single night.
You're thinking rotator cuff.
I am 99% sure we're looking at a rotator cuff pathology, not a pinched nerve.
Okay, so let's assume we've successfully identified it. The listener is nodding along, saying, yes, that's my arm, that's my night. This is where the source material pivots to solutions, and it was a bit of a curveball.
How so?
Because if my muscle is irritated and screaming, my first instinct is to rest it. Stop moving, put it in a sling, let it heal.
And that is what we call the rest trap.
The rest trap.
It's a logical assumption. If it hurts, don't do it. But with tendinopathy or these chronic muscle issues, rest is often rust. The source explicitly calls exercise therapy the most evidence-based approach.
It feels counterintuitive, though. My shoulder hurts when I move it, so I should move it.
You have to move it correctly. See, the rotator cuff often hurts because it's weak or the tendons have degenerated slightly. They can't handle the load you're putting on them.
Oh.
If you rest completely, the muscle gets even weaker. So when you finally go back to using it, the load is even harder to handle and the pain comes back worse.
It's a downward spiral. You rest, you get weaker, you hurt more, so you rest more.
Exactly. We have to reverse the spiral. The goal of exercise therapy here isn't just fitness, it's mechanotransduction.
Okay, that is a fantastic word. Let's unpack mechanotransduction.
It's the biological process where your cells sense mechanical load like lifting a weight or pulling a band, and they convert that into a chemical signal that tells the tissue to repair itself.
So you're not just strengthening the muscle, you're doing like structural engineering on the repair through movement.
That's it, but it has to be the right dosage. You can't just go do heavy push-ups. The source emphasizes targeting the rotator cuff specifically and the scapular muscles, the shoulder blade.
So we need to stabilize the foundation. But what about those trigger points we talked about? Can I exercise a chemical nod away?
Sometimes,
Yeah.
but often, if the trigger point is really active, the muscle is too inhibited to exercise properly. You try to strengthen it, but it just hurts and won't fire.
Which is where the interventions come in.
Exactly.
The text listed a few that sounded intense, but fascinating. Let's talk about dry needling.
This is a polarizing one for some, but the data is very interesting.
For the uninitiated, this is sticking a needle into the muscle, but not injecting anything. Hence, dry.
Correct. It's a thin, filiform needle, like an acupuncture needle. The clinician searches for that taut band, the trigger point, and inserts the needle directly into it.
And what does that do, apart from, well, hurting?
It creates a local twitch response. The muscle fibers spasm briefly, and then they involuntarily release. It's like hitting a reset button on a frozen computer.
So it physically forces the muscle to unlock.
Yes. It also brings a flush of fresh blood to the area, which helps clear out that acidic chemical soup we talked about earlier. It just changes the whole environment of the muscle.
Okay, a reboot for the tissue. But what if needles aren't your thing? The source mentioned manual pressure release. Is that just a massage?
It's a little different from a rub down. Manual pressure release is seeking out that painful spot and pressing on it hard and holding it.
It's the good pain.
It is. It's ischemic compression. You press until the tissue blanches, and when you let go, blood rushes back in. It essentially starves the trigger point of oxygen for a moment to force a relaxation response.
Now, for the cases that are really stubborn, the source went into some medical interventions. Trigger point injections, and even Botox.
Right. Trigger point injections are similar to dry needling, but you inject a local anesthetic, like lidocaine or sometimes a steroid. It numbs the area to break the pain cycle chemically.
But Botox, I think of that for wrinkles. How does that help shoulder pain?
Think about how Botox works for wrinkles. It paralyzes the small muscles so they can't contract and crease the skin. If you have a muscle in your shoulder that is chronically contracted and spasming,
Botox does the exact same thing.
it chemically blocks the signal telling the muscle to contract. It basically cuts the phone line so the muscle stops getting the call to tighten up. It's temporary, but that window can be enough to get the patient doing their exercises without pain.
And that seems to be the theme here. None of these things, needles, Botox, pressure, are the cure in isolation.
That is the critical takeaway. The passive treatments, the stuff done to you, buy you the relief you need to do the active treatments, the stuff you do. The exercise is what builds long-term resilience so the pain doesn't come back.
A text also had an interesting note on combination therapy. It said doing acupuncture plus injections might work better than either one alone.
It speaks to the complexity of pain. You're attacking the hardware, the muscle tissue, and the software of the nervous system at the same time.
Which leads to a warning in the text. You can't just guess. The rotator cuff has 4 muscles, right?
Yes. The supraspinatus, infraspinatus, teres minor, and subscapularis.
And if I just start doing random shoulder exercises I saw on YouTube, I could make it worse.
Absolutely. If you have an issue with the subscapularis, the rehab is very different than if it's the supraspinatus. You need to know exactly which muscle is the culprit.
So if I'm listening to this and realizing my pinched nerve sounds exactly like this referred shoulder pain, what's my actual first step?
First step, stop icing your neck, stop treating the wrong area. Second step, get a functional evaluation from a physical therapist or an orthopedic specialist who understands these referral patterns.
They'll figure out which muscle is the problem.
They'll move your arm, test your strength, and reproduce the pain to map it accurately. Then you start the work. You calm it down, and then you build it up with specific exercises. You fix the muffler, and the noise in the glove box goes away.
It really changes your perspective. We tend to think of the body as a collection of separate parts, arm, shoulder, neck, but it's so integrated.
It is, and that integration is both its strength and its weakness. It allows for complex movement, but it also allows for this referred pain confusion where the wires get crossed.
It brings me back to the check engine light analogy. Just because the light is on the dashboard doesn't mean the broken part is in the dashboard.
Exactly. And you wouldn't just put a piece of tape over the light and keep driving. You'd look under the hood.
I want to zoom out for a second before we wrap up. We've been talking about physical pain and muscles and nerves, but this concept that the brain can be tricked into feeling something intensely in the wrong place, that feels like it has bigger implications.
It absolutely does. And this is the thought I'd like listeners to sit with. We learned today that your brain can construct a vivid, undeniable reality of pain in your arm based on a confusing signal from your shoulder. It is a physical reality. You feel it, but it's a geographical lie.
It's a hallucination of location.
A hallucination of location, exactly. So if your brain can make that mistake with a simple pain signal, what other signals is it misinterpreting? When you feel anxiety, is it purely emotional, or is it a physiological signal from your gut or your nervous system that the brain is simply mislabeling?
Or when we feel emotional hurt from a conversation, are we reacting to what was actually said, or are we referring pain from a past injury?
Exactly. We are prediction machines, not objective observers. Our brains are constantly guessing. And whether it's shoulder pain or emotional stress, the symptom is rarely the cause. We have to be willing to look upstream.
Don't treat the noise, find the signal. That is a powerful place to leave it.
The only way to really fix the problem.
Well, for everyone listening, I hope this saves you a few unnecessary MRIs and gets you on the right track to fixing that arm ache. Stay curious, keep moving, and we will catch you on the next deep dive.